It's really nice to be invited to come and speak to you as an audience. I am a kidney specialist. I don't think people know too much about kidneys, to be honest, outside of the kidney world, or if they get a kidney problem. It's a silent disease. I probably guess that many of you don't even know your own kidney function, and it's only really an issue if the doctor says there's something going on with your kidneys that you start thinking about it. So forgive me for that, but it's really good to come to an audience and start talking about kidneys and infection. That's the other part of the work stream. So if I just move on, hopefully this works nicely. Going to touch on the theme that I've just talked about, kidney health, disease, infection, sepsis. And talk a bit about the kidneys, just so you can go away from this having understood a bit about what kidneys actually do for you and how hard they're working for you right now as you're sitting in your chair. Mention a case study from the work that we did on the MIC, and then talk a little bit about surgery and a bit about sepsis. So a little bit more about myself there in terms of my specialisation. So I'm particularly interested in acute kidney injury. That's when your kidneys completely pack in rather rapidly and they can't do all the things the kidneys normally would do. I'm a transplant physician as well, so I look after patients who've had their kidney transplants. And I've got very interested in sepsis now, and I'm the lead for sepsis for the Trust. And that fits in really nicely with my colleague here, Dr. Kerry Davies, who's not with us today. She's got a much bigger portfolio than I have. She's going to be a fantastic person to work with. I'm really pleased as well I can get kidneys together with something like infection, because of the problems we do have with our patients with infections. So Kerry's the principal clinical scientist in microbiology and IVD expertise developed during the pandemic, and you can read everything that's there. The theme will help us focus on technologies that will hopefully enable us to get earlier diagnosis in patients. Kidney disease, we only have a few very simple tests to monitor what's going on with kidneys. We don't have particularly good ways of really understanding what's going on with kidney function. We have a serum creatinine value, we have a urine output and some biomarkers such as albumin that we measure in the urine. We really don't know what's going on in the kidneys many times, and we have to think very hard about what might be going on, and sometimes we can do some fancy imaging to get a better idea, but there's a real dearth of expertise around in vitro diagnostics for kidney disease, and yet it has a massive impact on patients. Hopefully I'll be able to share that with you as we go through this talk. So what's the role of the kidneys? Let's move through this. Well, back in 2014 when we did Ipsos Mori poll, only half of the population knew that kidneys only produce urine. So we started a very backward point in terms of understanding of kidneys and their function. They do many more things than just pass urine. So when you've got kidney disease, you stop doing all these really important things. They are very important in looking after your bones, producing red blood cells. EPO is a substance that's produced by the kidneys. It's that substance that some people have taken over the years to boost their performance during the Olympics and other sports. They're very important in blood pressure regulation. They create the environment for the rest of your body to work. So if they're not functioning, then you get a lot of cellular dysfunction. And they excrete metabolic waste as also many different drugs. So 1,200 mils of blood enters your kidneys every minute, and 20% of your cardiac output is going through your kidneys also every minute. That's a big amount of blood going through your kidneys. So we filter about 180 litres of water every day. That's what your kidneys will be doing. But thankfully we don't pass 180 litres of urine. The kidneys are very clever. They're very clever organs, cleverer than many other organs. Maybe the brain trumps the kidneys. But they produce 1.5 to 2 litres of urine. So, this is something that's very close to my heart. I work with a charity, Kidney Research UK. Kidney disease is a public health emergency, and we're trying to get the government to start understanding that, and I'll give you some reasons why. So there's about 7 million people now in the UK who have chronic kidney disease. It's a silent disease. Many people don't even know they've got it. We're embarking on projects to reach out into communities, the underserved communities, to try and identify people with kidney disease. It's increasing. It's increasing as the demographic in our country increases. The most common cause is diabetes. More people have chronic kidney disease than diabetes globally. And look at the cost to the NHS. 3.2% of the NHS budget goes on kidney disease. 850 million people globally have kidney disease. It's the third fastest growing cause of death globally, and it'll be predicted to be the fifth ranked cause of death globally by 2040. Some figures to take away. So it's a global phenomenon. So things we can do here in our country, we can look to try and help other people in other countries who are less fortunate than ourselves. So it's the big topic that everyone's ignoring. So this is a case study. I am still the Associate Clinical Director until I think the 1st of April, when I move across to the HRC, of the MIC. And this was a case study that we did, and Mike Messenger was very involved with this study, so you might well remember that. What was the issue? Well, when you do CT scans, you give them contrast dye. That contrast dye can be harmful to the kidneys. So, NICE recommended, I was on the NICE committee that recommended this, that you check the kidney function within 3 months of having a CT scan with your contrast. However, people were turning up for their CT scans without this blood test, and they were being turned away. So you're missing really important studies for people that need that. So that the patient flow is not good there. We need to improve it. So a team from Mid-Yorkshire, we worked together with them. Mike Messenger was absolutely instrumental in this. We came together and we performed a feasibility test, and then we went on to look at different point-of-care testing. This then led to a MedTech innovation briefing with NICE, and that led to a diagnostic guidance being produced by NICE. And this was regarding the use of point-of-care devices for patients if they pitch up to the CT scanner and they haven't had their EGFR, their kidney function test, done within 3 months. So that's the sort of thing that the MIC was able to do. What you need to really generate, and I've sat on a number of NICE committees over the years, I'm a NICE clinical expert, is you need to generate the right data. If you want to get your products out there into the NHS, you need to generate the right data to take to NICE. And 3 of the papers that were used to get this through on NICE were generated through the MIC. So let's just think about surgery and kidney disease. I'm a specialist in kidney transplantation. I'm not the surgeon, I'm the physician. I look after the patients before they get the surgery. I work with the surgeons post-surgery on the wards, and then I look after them in the clinics afterwards. There's been no new diagnostic test brought into the clinical pathway since early 2000. There's a real need. Our patients with kidney transplants, there's about 34,000 patients in the UK with kidney transplants. Small number, but that number are very important, because if they lose their kidney transplant, they go on to dialysis, and the number of patients on dialysis is about 30,000, and the cost of dialysis per person every year is about £34,000. That's a lot of money for the NHS. The kidney transplant is the best form of treatment for somebody who has kidney failure. It gives them their life back. So there's big issues there with infection, cancer, and loss of the kidney as well. And we really don't have good diagnostics for this. So we do a lot of transplants in Leeds, and I won't dwell too much on that. But if you look down here now, we're increasing our ability to try and offer transplants to patients who have been on dialysis for 10 years. There's new therapies out there. And just this morning, I've interviewed a candidate. We've appointed her. Adrian Seitz has been appointed now as our transplant immunologist, and she's taking forward such that we've done 40 more kidney transplants over the last few years because of the techniques that she's employed in the lab, but we still don't have any new good diagnostics. There's a new medication, Lifidase, which has been funded by NICE, is recommended by NICE. It can remove all antibodies from patients immediately to them receiving a deceased donor kidney. But those patients are at increased risk of infection during that period of time and rejection, and we need improved diagnostics. So here we can see patients who have kidney transplants are at very high risk of a whole range of different infections. One of our colleagues, Matt Welby-Smith, he's working over with Andrew McDonald in the university now, looking at BK and how we better tackle patients with this rare condition but devastating condition. I say it's devastating because patients will tell you if they have a kidney transplant, if they have any other illness that goes on at the same time, the worst thing that can happen to them is they lose their kidney transplant during that other illness. So patients with kidney transplants are increased risk. We need better diagnostics to look after them. What have we done so far in Leeds? Well, my colleague Sunil Dagger, he's a specialist in looking at the immunological side of things. He's been working with Thermo Fisher on a C1Q assay, an Immucor on a C3D assay. I'm looking at double-stranded DNA as a marker. I'll just show you a slide on that in a second. And Sunil, we all know about AI and the excitement around AI at the moment. He's working with a company, Sibyltech, and they're looking at predicting poor outcomes in patients with kidney transplants, and that's proving very, very interesting at the moment. So this is a study we got funded by Leeds Hospitals Charity, and thank you to them for this. And we got money from Omixcon, or rather reagents, worth over £100,000. And what we're trying to do is bring together with what we have at the moment, which is donor-specific antibody measurements, to see whether the use of identifying double-stranded cell-free DNA, That will be DNA released by the kidney. The kidneys come from somebody else. It's not the person's own DNA. Can they identify that going up before the DSAs, the donor-specific antibodies, go up? Can we see that as a marker of injury in that patient before we move on to doing invasive? And patients hate this. If you have any patient who has a kidney transplant, they really do not like needles going to their transplant. They would have to have a biopsy to prove what's going on. So that's what we're trying to do with this. Other centres are now following us, and they're also, this is getting very interesting. So let's just think about post-operative acute kidney injury, and why is that important? Why are we interested in acute kidney injury in surgical patients? Well, I'm really excited that we've come into the HRC and we can really start to focus on this better than we ever have done before. So basically, AKI can be seen in about 6% of patients who have surgery in that study, the top. The second study, we can see that the mortality rate in patients who get an episode of acute kidney injury, and this is the same for acute kidney injury in any condition. If you get acute kidney injury, your risk of death goes up massively compared to patients who don't get acute kidney injury. It's a marker of vulnerability in that individual patient. And then we can see in cardiac surgery that 25 to 30% of patients get an acute kidney injury. And at the moment we're working with a charity. We've got AZ and Evitech who are funding a piece of work around a biobank project, Nurture AKI. And we're looking to involve Leeds, Edinburgh, Bristol, and now King's probably in that study going forward, and biobank a whole bunch of samples of patients who get acute kidney injury, because pharma have a number of different therapies that they're ready to use in these patients, but they need the companion diagnostics to guide them. This links with national priorities. NHS England now has funded the Renal Service Transformation Programme. On here we can see acute kidney injury, chronic kidney disease and transplant. We want to work, as you can see here, in conjunction with national bodies, research, patient and charity bodies to improve what we're doing for patients with kidney disease. I want to thank a number of people who've helped over the period of time with what we've done in the MIC. There's not enough time for me to talk about all the different things we'd like to do. If Kerry was here, she'd be talking about sepsis, and not just sepsis associated with what I've just said, but sepsis in a broader context and the effects sepsis has on a patient following their operation. You can do all these fancy operations, but if you get patients getting sepsis, acute kidney injury, their outcomes will be worse. We need to be able to identify that earlier so we can put some measures into place to ameliorate the damage to those kidneys. I'd just like to thank you for your attention. Thank you.